Welcome to Doc Talk, your go-to podcast for exploring the dynamic field of clinical emergency medicine. Each episode, we delve into real case scenarios, from mastering point-of-care ultrasound to excelling in airway management and ultrasound-guided regional anesthesia. Our discussions aim not only to inform, but also transform your clinical practice. Your next significant clinical breakthrough begins right here.
So shut up, sit down, start listening. This will change your life.
All right, we're going to talk here about cryoneurolysis. This is a this concept has been around for a long time. There's a lot of research in cryoneurolysis, but the devices where you can practically do this on a patient percutaneously haven't been around all that long. So we just started using it in our emergency department. Tom's been using it in his. What we envision using this for mostly is rib fractures. So here's what cryoneurolysis is. You freeze a nerve to somewhere between -20 to -100 Celsius. It causes a reversible injury to the nerve. The nerve reliably grows back, but it takes 2 or 3 months, depending on the length of the nerve. That's ideal for a rib fracture because the intercostals don't have too much motor function, and if the nerve is going to be out for 2 to 3 months, it gives the person time to heal their rib fractures without any pain. So,
And I think, so this is a great step forward. Ultrasound-guided regional anesthesia was foundational, allowed us to see all the benefits of using local anesthetic to anesthetize things. So we started doing a lot of pain blocks for our hip fractures and inferior ramus fractures. And with those, you can either use, bupivacaine, maybe you put in a catheter into a pump for a few days, or maybe you use an Exparel. So you get, 48, 72 hours of analgesia. And it really transformed the way that we cared for our patients. The patient satisfaction was phenomenal. And so that was just ramus fractures, hip fractures. When you get into things like rib fractures that are notoriously painful, and when at a large referral center like you guys are at, putting the catheter in and infusing that and allow that to go for, you probably leave those in for 3, 4, 5 days, maybe a week or longer. And you just see the dramatic difference it makes in the patient's experience to be older and have your hemithorax fractured is a very painful thing. It increases your mortality for sure. And so building upon that ultrasound-guided regional anesthesia and seeing the benefit of that, the next question is how could we do this and help it last longer? Getting 3 days of relief is great. Getting a week, better. But when you start talking about cryoneurolysis, you're talking about getting up to 3 months. That is entirely a game changer. It makes a huge difference from the patient standpoint. And that's really what this is. This is cutting edge, but very obtainable, very doable. And for emergent conditions that are horribly painful, such as pelvic fractures, hip fractures, rib fractures, proximal humerus fractures, it's just a great technology.
yes, there's motor sparing nerves. Of course, intercostals are one of them for rib fractures, but there's a motor sparing shoulder block, a motor sparing hip block that you can learn to do. So you can use this in more areas, but mainly we're going to use it for ribs. So here's what happens when you freeze a nerve. It disrupts the nerve. So the nerve, but if you don't get colder than -100, the architecture of the nerve is still intact, and it's going to grow back. Here's kind of a schematic showing what it does. It kind of damages the nerve, but not the architecture, and then the nerve regenerates at 1 to 2 millimeters per day. So
a question, Rob, that I have often entertained is, does it grow back with the same sensory distribution, or do you have a maldistribution of your sensory input? In other words, do they go back to the same path?
It should be the same. It's the same nerve going to the same place. So some people have reported, I haven't seen it, we haven't had this very long, but the people get some paresthesias and stuff while the nerve's growing back, which that's what you would expect.
And then you're probably going to get to this, but does your device have temperature controls on it so that you can keep it in that -100?
Oh, it goes to 88.
Got it.
88 below. No, I'll explain that.
Okay.
So this is a device. It's called Iovera. You you basically put a cartridge into a nitrous oxide cartridge into this area. You flip that switch and this thing opens. And then you take this plastic cover off and you put a specialized needle on the end. So here's a cartridge. It's just nitrous oxide. These are very cheap. But when nitrous oxide, the boiling point of nitrous oxide is minus 88 Celsius. So when it goes from liquid to gas form, it drops into minus 88. And somehow they'd figured out how to get that gas to go down into a 20 gauge needle and circulate. And just somehow just get the tip of the needle cold, not the whole needle. So, which is pretty cool. So here's the specialized needle.
Super cool. Negative 88 degrees. It lasts for 3 months. It's a very inexpensive device.
Yeah.
I think the handheld device is about $5,000.
Yeah.
And the clinical impact is amazing.
And you see a black line on the needle there. You can, below that black line, it gets cold. On this side of the black line, it doesn't. And the reason to know that is that you want that under the skin. Otherwise, you're going to cause a little frostbite at the spot. And I have done that a few times, and the patient doesn't, it hurts. I don't think it's a big deal, but generally you want that black line below the skin.
One question: how deep is that black line, and does this relegate you to just deeper blocks?
You can go obliquely and get that under the skin. I've done this in really skinny patients, and their intercostals are very close to the surface, but you can usually get that black line below the surface. So, yeah, the whole needle, I don't know how long, 90 millimeters, I guess. So it's a nice size needle. It's only 20 gauge. It's a blunt needle, so it's like a nerve block needle, but it's hard to push through the skin. So, but it's very flexible. So you can bend the needle. If you need to change the shape of it, you can bend it. It doesn't break, which is nice and still works. So this is a technology that the gas goes down into the tip and circulates without ever coming out. So nothing goes into the patient. It's just cold. And here's what happens when it does go down there. It creates an ice ball on the tip of the needle. And it's about a centimeter long, or 15 millimeters, I guess. But you can see that on ultrasound. You can see the ice ball form. And so you can tell if it's in the place where you want it to be. Like when I'm doing this when I'm aiming it for an intercostal nerve, I've had it, sometimes in bigger patients, you can't see the needle so well with ultrasound. But you can see where the ice ball forms. If the ice ball doesn't form in the place where you think the intercostal is, just do it again. So I've done it a few times where it's not deep enough, and I see the ice ball. It's not near the intercostal, so just try again. The cartridges, one cartridge allows you to do 5 freezing cycles, and of course the needle you can use as many times as you want on any individual patient. So I usually use at least the whole cartridge if I'm going to use one, and maybe 2. This is what we're dealing with. Usually not one rib fracture. It's multiple that hurt the most. Lower rib fractures seem to hurt a lot more than uppers. This is a patient I saw a few weeks ago who had what was called a non-displaced rib fracture. He had like 4 of them, but he was 80 years old. On the CT, they just look like lines, non-displaced. But this is the difference between the CT scan, which is a split second, and dynamic ultrasound, which shows you what actually happens when the guy breathes. This is the distal end of the rib, and this is the proximal end of it. Of course, the proximal end doesn't move because it's not broken. The distal end is moving as this guy breathes. This is like his 10th rib, and it's every time he moves or breathes or does anything, it's moving around, and he's having severe agonizing pain. This is just with light breathing.
So
What we see.
I just got to comment on that because anybody who has done this for any length of time, an 80-year-old guy with a rib fracture like that, you're running about an 80% chance that he's either going to have atelectasis and pneumonia, or you're going to overdose him on narcotics.
Yeah, and this guy, he lives by himself. He fell down at home, and he could not get himself off the floor. He's a pretty healthy guy, but he could not manage to get off the floor because his ribs hurt so much. I think he had 4 fractures, but he was just in agonizing pain. Could not really cough without horrible pain. So this is just breathing. This is what happens when he coughs.
Impressive.
And yeah, you can see why that hurts. And This is not something you can tell from a CT scan. The CT scan was read as for, non-displaced fractures. So it
And,
doesn't really tell the story.
and to Dave's point, when you start giving these people narcotics, especially as people age, right? They get delirium, hallucinate,
Yeah.
they get constant.
That's why they end up dying from,
Well,
part of why they end up dying.
they're not breathing any better. They're breathing more poorly. It's just this disaster, but we do what we've always done because we haven't had great tools available. And even if you did a block with Exparel, you're going to get a few days out of that. Put in a catheter. I guess you can leave that in.
And people do single shot blocks for this. To me, that's just, bordering on cruel because it gives a patient a brief respite from their horrific pain. But in the long run, it doesn't do anything. It makes you feel great because when they left the ED there to go upstairs, they're pain free, but you don't see what happens upstairs, which is they just sit around and can't cough and don't breathe right and get pneumonia and die. So you really need longer term relief. That's why we used to have a service where we put in catheters for these people, but they would sit up, those catheters would stay in for a week to 10 days. That would get them over the worst part of it, but that's a huge hassle putting in catheters and following them. And so this is much easier. You do the procedure, walk away.
And we're really at incremental kind of evolution of pain management.
Yeah.
And we've really gotten to a point.
This is definitely a huge step forward.
Everyone wants to be giving people narcotics for all kinds of reasons, whether they're young or old. The single shot block it's quick and it's easy, and you feel really, really good about yourself. Liposomal bupivacaine, again, you can get 3 days, but at some point they're going to be super miserable again. And this is just the next evolution of that, and it's got tremendous.
This is what you would want if you had rib fractures.
100%.
And how everyone can say that at this point. So this is the procedure. This is actually just some local anesthetic being given first. So this is a nerve block needle coming in here. You can see the echogenic markings on it. And you see how close we are to the pleura here? Because the intercostal is right there, right? So we want to get as close to the pleura as possible. And I found that if you give 5 milliliters of some sort of local anesthetic right here, and it'll push the pleura down this way, and it'll give your Iovera needle a little place to go into without hitting the pleura, which is nice. The next thing we do is put the Iovera needle in there. You can see that there's much more space there now than there was on that other view. That's because we injected 5 mils right there. Now this is the Iovera needle. This is before we activate it. You can't see an ice ball, but the ice ball is going to form right here under the rib. And now you can see an ice ball. See that black? It looks like a gallstone.
So to clarify, the Iovera needle isn't a hollow bore needle. There's no injection done through that.
Right. And when you activate it, it's a 106-second cycle, because the reason for that is because it takes about 30 seconds for this ice ball to form. And then you literally cannot pull the thing out because it's frozen to the tissue around it. So you're going to have to sit there and be patient and watch it count down. It counts down from 106 to 0. And when it gets close to 0, you can start tugging back on the thing a little bit. And when it's thawed out enough, it'll slide out. If you see the ice ball form right here under, in the perfect spot, it's going to be a great effect.
Yeah, when you're doing these intercostal blocks, you have to understand you're going to the undersurface of the rib, the part of the rib that we were all told to stay away from. But you go in, did the intercostal block, and expanded that space out, and then you come back and get right up underneath there. And you're going to essentially, what I do is I end up hitting the rib with the needle and just kind of walking it underneath there, as you can see it, and then delivering the.
And there is a risk of a pneumothorax, definitely. I tell these patients that you might end up getting very reasonable chance that you might get a pigtail chest tube after this. But if it was me, I've had rib fractures a couple times. I'd much rather have a pigtail chest tube and no pain than horrific pain from rib fractures for the next several weeks. So I think it's worth it. You obviously don't want to create a pneumothorax, but if it's a small price to pay to get rid of the pain.
Why do you get a pneumothorax out of this? You have a blunt tip needle.
Well, as it turns out, it's unlikely, I think. I've actually been down there, activated it, didn't see the ice ball, and wondered, why don't I see the ice ball? And I was under the rib, definitely hit the pleura, and it didn't create a pneumothorax. So I don't know if it's the blunt tip needle or it freezes the hole that you just made in the lung and seals it, but I was definitely too deep. because as I pulled it out, I was like a centimeter deeper than I wanted to, at least at least once, maybe a couple times, and it didn't create a pneumo, which surprised me. So the chance of pneumo might be less than I think, but you are getting the tip very close to the pleura. So
And for this to work, a lot of times you need to hit you're gonna have to hit the intercostal nerve below, one below where the fractures are, and one above.
yeah,
So if you have, 3 levels, you're gonna end up with at least 5 levels that you're gonna block because there's crossing of the innervation. So this procedure does take a little bit of time.
what I do is I look at the CT scan. I mark I go to the ribs that I know are broken. I First of all, I scan them to see like where the fractures are because you can see them easily on ultrasound. And then I, go one above, one below, and then just make a plan as the line that I'm going in and probably do like 5 ribs if they have 3 fractures or 6 ribs if they have 4. So and if you happen to open up a second cartridge, the cartridges are cheap. So if you if you want to do 10 spots instead of 5, it's probably going to work better.
And the response is essentially immediate. You disrupt the nerve right
Yeah.
away.
If you do it without local anesthetic, when you push the button, they feel it and it hurts for about 30 seconds and then it stops. But most people don't tolerate that very well. So that's another reason to go down there with local anesthetic. Put some local anesthetic in the spot and then go down and freeze that spot. So in that 80-year-old patient that we just talked about, when I was done blocking him, he didn't want any local anesthetic. He just said, just do it, which I did. And after I did like 5 or 6, I think 6 spots. And when I froze the last one, he said, my pain is completely gone, completely gone. And he was still going to get admitted to the hospital because he fell and he was going to see physical therapy. But after thinking about it for a couple hours, after the block, he said, the reason I came was because I had pain and it's gone. And you tell me it's not coming back. And he signed out AMA and took an Uber to the grocery store because he needed groceries. So I called him a couple days later and he said, no, I'm fine. I'm not coming back to the hospital. I'm totally fine. I have someone checking on me every day, but it doesn't hurt anymore. So
The guy who couldn't get up off the ground.
he was going to go to the ICU.
He couldn't get up off the ground.
80 years old with, 4 or 5 4 rib fractures or whatever.
Those factors are quite high.
Yeah. So that's,
Do you still incentive spirometer this guy?
he never got to that point where he had an incentive spirometer, but a patient I did, a 75-year-old woman who I did 10 blocks on the same week, she got up to the hospital floor. She had almost no pain. She had like 1 out of 10 pain when I got done. And previously she couldn't even sit up in bed. She blew the first time respiratory therapy came to see her, gave her an incentive spirometer, documented she did 2,000 on the incentive spirometer. They wrote a note that said they're signing off. And then she only spent like 2 days in the hospital and went home. So in our limited experience, this works great. It does look a little risky when you're doing it, but hopefully the pneumothoraces are rare.
Are you using this on other sites, sensory-only sites?
I've done it on a shoulder. If you go do multiple spots around the back side of the shoulder joint, it'll get the whole shoulder
Condition.
for a cancer patient.
Proximal humerus fracture. So generally, proximal humerus fracture, old people, rumble hurts a lot, right?
Yeah.
They're not moving there anyhow, but you can come in suprascapular, also come back here, posterior axillary, and get those. They'll lose abduction for a few weeks. So
Yeah,
motor.
if you just go around the back side of the shoulder, they won't get any motor deficit. If you do the suprascapular, they'll get a little bit of deficit, but they probably won't notice it if their arm
I have
broken.
a humerus fracture. I will take 2 weeks of decreased range of movement. But again, it's just a painful condition. It hangs, it heals, and you eliminate that. And then we use it, essentially, we do a ping block for our hip fracture patients. Almost all of them will get a ping block with local anesthetic. Then we'll come back with the Iovera. That's going to cover them through the immediate period and also take them post-operative. And then ramus fractures, right? Weight-bearing fracture, painful, generally old people. And again, we'll use the Iovera and do a ping type block.
So when you actuate it, is it on a timer that self-stops them? And for any malposition, it's probably necrosing tissue. True?
It's probably a little spot, but it doesn't bother veins and arteries. aren't really um, aren't really bothered by it because
Floored by it.
they have warm fluid running through them, and then so it's probably causing probably any damage it causes it doesn't cause death of tissue probably, but much like a brief freeze.
15 millimeters long, and then generally what's the other dimension of the ice ball that's formed?
It's about 7.5 millimeters.
Yeah. Okay. So it looks like a teardrop when you're done.
Exactly.
Yeah, yeah, and so there is some data about doing intercostal cryoneurolysis, but these studies are done in the operating room while they're there to plate ribs and they're inside the chest so they can see the intercostals and just freeze them using a different device, not the Iovera, but you could use that too. But this is interesting. In this study, they um they did they froze some of the ribs and then they plated some of them and froze them, and they had good outcomes, better outcomes if they froze the nerves versus just plating them. So, and you can see there, 71% less opioids, uh, more going home earlier, less tracheostomies, which is always good, shorter ICU stay by 1 day. So, um, I would imagine when we start doing this percutaneously on a regular basis, we're going to be able to publish something that shows a lot of benefit. So, it's not there yet, but soon we'll have that data.
So you didn't have the skill set, how would you go about figuring out how would you get good at this so you could become proficient?
I would practice on a cadaver. That's what we
Sure.
train on cadavers.
Yeah, I think for emergent uh, and acute care, regional anesthesia, I think foundationally you get good at ultrasound-guided regional anesthesia, and then from there, then you build on that. And certainly getting to a course, and I've been to plenty, but coming to our course where there's 4 cadavers to do needle-guided procedures, there's live scanning models, there's sim-based stuff. It really gives you the opportunity to really get the hand-eye coordination, using the probes, and just getting comfortable with the foundational blocks. And then the next level is you introduce the Iovera, which is just a small incremental skill, but profoundly impactful as far as from the patient standpoint.
Yeah, and in our course, we practice all this stuff on cadavers, and once you do it on a cadaver, there's not much difference to doing it on a real patient.
And like the other things that we've talked about, learn it from someone who does it.
Yeah, it's good to learn learn it from someone who actually has done it a lot. Uh, so there's not a lot of people who have done this Iovera a lot, but I think, like you said, it's just a extension of any other regional anesthesia skill. So it's seeing a needle with the ultrasound, and that's all there is to it. So
So super low cost. I mean, if any one of us had one of these painful conditions, we would want this done to us. 90 days of pain relief compared to a few hours or a few days this is an amazing opportunity for the patient. The device does not cost very much. The technology is portable. It's easy to use. There's not a good reason to not start doing this.
two of the people I've done it are family members of providers that I know that called me up and asked me to do it because their loved one or a friend had a fracture. So it's definitely it's definitely what people want, and what you would want for your loved ones if they had broken ribs. So
Last question. Is there any difference in time for regeneration from bigger nerves to smaller nerves, for example?
longer the nerve is, the longer it is, the longer it takes to regenerate. So
The
one
longer
to
this away from distally, you mean?
yeah.
Okay.
So it regenerates by 1 to 2 millimeters per day.
Okay.
So depending on where you are, I'm sure the posterior ones regenerate quicker than the ones farther around anteriorly. So
Have you done this for example, non-ambulatory lower extremity stuff?
I have not. So y- you wouldn't really want to do it on a motor nerve, and like most of the leg is going to be, it's going to be hard to avoid a motor nerve. But in certain circumstances, like PM&R uses this on nerves that like a spastic extremity. They'll use it on the nerve to that extremity, and they're going for motor nerves to try to avoid relieve the spasticity. So
And I think as this evolves, see more and more utilization, you're going to see more applications. These are just some of the basic ones that we see almost every day. and being able to really extend that period of analgesia, avoiding narcotics and other things that can cause all kinds of side effects. Huge step forward.